Next, we have Epstein-Barr. This is a different herpes virus. It's not as closely related to the HSV and VCV viruses. We most commonly see Epstein-Barr associated with infectious mononucleosis, or mono. This virus is one of the herpes viruses that is capable of causing cancer. It can immortalize B cells. And there are a couple of different types of cancer it can cause, including Burkitt lymphoma, Hodgkin disease, and nasopharyngeal carcinomas. The receptors for Epstein-Barr virus are found on B cells and some epithelial cells of the upper respiratory tract. The virus can replicate in B cells or in specific epithelial cells that allow it to replicate. It can cause latent infection in memory B cells, and it can stimulate and immortalize B cells. The disease symptoms that a patient experiences result from an inappropriate immune response. Generally, we see things like mono in young adults, college-age students. Because they have a very robust immune system, we see an overactive immune response, and that gives us the symptoms of mono. Swollen lymph nodes, swollen spleen, tired, fatigue, sore throat, but that's what you have, the overactive immune response. Now, if you have a lack of control, so you have some type of immune suppression, that can lead to what we call lymphoproliferation, which can lead to the cancers that we see. So I mentioned the symptoms, swelling of the lymph nodes, spleen, liver, malaise, fatigue, sore throat, and that's caused by the activation and proliferation of T cells that are produced in response to the infected B cells. Now, children who have a less active immune system also tend to have less severe disease. But college-age students, man, it's a tough one. We will talk about the diagnostics, but one of the things that happens when you have these infected B cells is what's called heterophile antibody production. So I think the scientific way I'm going to say it is wonky antibodies. Basically what happens is you get antibodies produced because of the infection in these B cells, and the antibodies are not quite right. And they're called heterophile because they'll actually be cross-reactive with proteins from other species. So that's a pretty diagnostic feature of Epstein-Barr. When patients have the infection, it's estimated that there's one infected B cell per milliliter of blood. It's thought that approximately 70% of people in the US are infected by the time they're 30. And you may or may not know, depending on how old you were when you were infected. It is transmitted in saliva, so kissing, sharing utensils. 90% of patients who are infected will shed the virus for life. We see transforming Epstein-Barr, so the Epstein-Barr that causes cancer, in patients who have malaria. So this is actually relatively common in Africa to see Epstein-Barr leading to cancer in patients who are immune deficient and just basic genetics. If bad luck of the genetic draw could predispose you to transforming Epstein-Barr. So this is a case in a patient who's immune compromised. It's a boy who has a disease called Duncan disease, and we'll get there in just a minute. So this patient who had Duncan disease presented with reduced levels of IgA. Remember, IgA is our secretory antibody, and it's super, super important for protecting our mucosal surfaces. A history of thrush. Thrush is an uncommon manifestation of a fungal infection. We typically only see thrush in infants. So to see it in an older child is not common. and recurrent episodes of otitis media, so ear infections. So the kid's immune compromised, right? This member of the Duncan family had an X-linked recessive progressive combined variable immunodeficiency disease caused by a particular mutation that prevents proper communication between B and T cells. So the kid is a member of a family called the Duncan family, and the disease was named after them because a number of individuals in the family had the same disease. It is an X-linked recessive disease, so a number of male members of the family had the disease. Think back to genetics. So he's immune deficient. After exposure to Epstein-Barr at the age of 11, he did not develop antibodies to Epstein-Barr, but generic levels of IgM increased. So he had more antibodies produced, but they weren't Epstein-Barr specific. And Epstein-Barr positive B cell lines grew from his blood. Establishment of the B cell lines was indicative that he lacked T cell control of viral proliferation, so he couldn't stop the virus from proliferating. At the age of 18, he was treated with red cells for an issue with his red cells. 9 weeks later, he developed mono with fever, swollen lymph nodes, tender liver, swollen spleen, lymphocytosis with a predominance of atypical lymphocytes and a positive, they call it a monospot test. It's a test for Epstein-Barr. Within another 6 months, he was A-gamma globulinic. So I want you to, let's look at the word. A, so lacking, gamma, globulin. So he had no IgG and no detectable B cells. He suffered from Haemophilus influenza and Mycobacterium tuberculosis pneumonias. After an additional 5 months, B cells were again detected. The onset of infectious mononucleosis at 18 may have resulted from a new infection or reactivation of the earlier infection. This case illustrates the unusual nature of Epstein-Barr and other infections when the immune response is compromised. So again, when you have an immune compromised patient, you can have weird manifestations of disease. Some patients will develop chronic symptoms. Again, most don't, but they can. So you would diagnose it by the symptoms. So is the patient experiencing a fever? Well, I guess that would be a sign, but do they not feel well? Do they feel really tired? I'm talking like extreme tiredness in a young adult who normally is like an Energizer bunny. Irregular appearance and numbers of white blood cells, those weird heterophile antibodies, viral DNA. Now, there's no vaccine. So then the question is it best to be infected as a child because the disease is less severe? And that's something, again, to think about. I would never recommend that you purposefully infect a child with Epstein-Barr, but if 70% of us are going to get it anyway, is it best to get it as a child? The last herpes virus we're going to talk about is Cytomegalovirus. This is, again, a very, very common viral infection. All the herpes viruses are. Estimated to affect between 50 to 80% of adults in the US by the age of 40. The reason we talk about it, even though you may never have heard of it, is that it is the number one viral cause of congenital defects. Approximately 15% of stillborn children are cytomegalovirus positive. So it's a significant cause of mortality. It is important also in immune compromised patients. They'll experience more severe symptoms. Anywhere from 90 to 100% of patients being tested for sexually transmitted infections are positive for cytomegalovirus. It is the largest of the herpes viruses, and it does carry its own mRNA, and it's relatively slow to replicate, which may help promote its latency. This is one of those where patients who are thinking of having children, you may want to, check the CMV status of both parents. If you're both negative, that's great. If you're both positive, that's fine too. If the person who's going to become pregnant is negative and the person helping with the pregnancy is positive. So basically, if the mother experiences the first CMV infection during pregnancy, that is the highest risk for the fetus. So you'd want to make sure you either had it or that you both didn't, in order to limit the potential for defects here. The virus can prevent antigen expression, so it interferes with both class 1 and class 2 MHC, and that helps hide it from the immune system, because if the MHC is not expressing any antigens, then the immune system doesn't know what's going on. It can also inhibit attack by natural killer cells, and it encodes its own protein that looks a lot like IL-10. And IL-10 is what some people will call an anti-inflammatory cytokine. IL-10 is a cytokine that kind of tamps down the immune system. So cytomegalovirus encodes a protein that looks a lot like that prevents a T helper 1 response. In adults, rarely causes symptoms. Even if you get the infection for the first time, you most likely will never know. It is found in most fluids and secretions, and the highest concentration is in the semen. So cytomegalovirus is present in a large percentage of medulloblastomas, which is the most common malignant brain tumor in children. In a study of these tumors, cytomegalovirus induced inflammation and promoted the production of interleukin-6, vascular endothelial growth factor, and prostaglandin E2, which promoted the growth of the cells. So all of that, especially the growth factors, are really, really scary when cells produce them, because that can lead to tumor formation. Treatment with a nucleoside analog and an anti-inflammatory drug was able to stop the growth of the cells. So does cytomegalovirus cause these cancers, or is it just a correlation? Not entirely sure, but it seems a lot like it could be a causative factor. Predominant presentation in children and adults is asymptomatic. There are other forms, but in neonates is where it's most dangerous. And then, of course, in our immunosuppressed patients. And typically, this is going to be our HIV patients. Normal patients will be asymptomatic carriers. Some of them may experience symptoms that resemble mono caused by Epstein-Barr. However, the difference is patients that have mono symptoms because of CMV instead of Epstein-Barr are going to be negative for those weird heterophile antibodies. If a neonate is infected because the mother was previously seronegative but then got the infection, that's significant disease in the neonate. Patients who have AIDS or are otherwise immunosuppressed can experience multi-site systemic disease. It can be diagnosed by serology, histology, cell culture, testing for nucleic acids. Nucleic acids are probably going to be the easiest, and nucleoside analogs could be used in immunocompromised patients.